And now from the Primary Care Access Network, we're going to get to hear from Margaret Brennan, who's a Primary Care Access Network Administrator in Orange County Medical Clinic, and Maureen Kursmarski, Regional Director, Government and Public Affairs, Florida Hospital.
Excellent.
Thank you.
Good afternoon. I'm Maureen Kursmarski, and I'm with Florida Hospital in Orlando, and I'm voluntary chairman of the Primary Care Access Network. Because we're from the South, we call it Pecan. Today, we're going to talk about 3 R's of government: response, responsible, and replicable. First, response. In 1999, Orange County government ran a clinic for 5,000 uninsured patients. Then chaos hit. A public clinic and 2 hospital ERs abruptly closed. The community demanded solutions. Orange County government responded. It convened local health partners, studied best practices, and set a vision for an integrated, comprehensive, affordable health care system that would leverage new and existing resources. Orange County pulled together 20 safety net providers to help build the system of care: hospitals, the health department, federally qualified health clinics, faith-based groups, the medical society, and others. They became Pecan. Pecan is not a health plan, not a 501c3, not a health taxing district. Pecan is simply a public-private collaborative healthcare system initiated by county government. Pecan now serves 110,000 patients, all uninsured, like the very low-income woman with advanced breast cancer who wasn't poor enough for Medicaid. Margaret's going to tell you some more.
Hi, I'm Margaret Brennan, and I'm the Pecan Administrator with Orange County Government. The second R is responsible. Today, Orange County spends about the same dollars, but uses the intergovernmental transfer programs to draw down a federal match. This money, about $15 million a year, funds services within the Pecan network. In addition, 1,600 volunteer medical professionals donate $5.3 million in care, and other partner contributions total $30 million without the hospital charity care. Orange County's per-patient cost has dropped to $157. Our partners operate 10 primary care medical homes, 10 volunteer faith-based clinics, and a secondary care clinic serving 10,000 patients. Partners also co-locate for behavioral health and dental care, imaging and lab services, and skilled nursing and social services. Case managers navigate our patients through the system. Every sustainable project needs evaluation, and over the last 9 years, Pecan has produced a 25% reduction in non-urgent uninsured ER visits, a 95% rate of self-reported health improvement, and greatly improved clinical outcomes for heart disease, hypertension, and diabetes. Most importantly, Pecan changes lives. For example, a newly uninsured man had 2 detached retinas, and a private physician wanted $35,000 up front. A case manager worked with a teaching hospital to save his vision. A homeless man lived with a broken jaw for 5 years, and it had fused shut, and he could barely drink through a straw. At just 100 pounds, he was literally starving to death. A surgeon and hospital donated his care and saved his life. And the middle-aged breast cancer patient that Maureen mentioned earlier is in full remission and attending college, saying that her experience gave her life new meaning. A major key to Pecan's success is aligning partner culture and values around a shared mission. You've heard of leaving your agenda at the door. We don't. Pecan wants the agendas at the table. We believe in consensus, not compromise. We set priorities and encourage ideas during the meetings and sometimes in the parking lot. We have intentionally fostered a culture where process and trust building are just as important as our other outcomes. Our county commission and mayor believe in Pecan and have protected it during many tough budget years. And our 3 hospital systems and other partners remain fully engaged, averaging 90% attendance at our board meetings. Pecan is sustainable and well-positioned to weather political will.
The third R is replicable. Pecan's already been replicated in 4 counties in Florida. Our governance model has served as a sort of a la carte menu, adaptable to their needs. These Pecan lookalikes were all initiated by local governments or state legislators. Pecan has changed the way Orange County government does business. Other public-private collaborations around mental health emergency and jail issues have adopted our model of convening partners, evaluating need, and leveraging resources. The Pecan model has been culturized in Orange County. Pecan is responsive, responsible, and replicable government at its very best. Best of all, it's the right thing to do. Thank you so much for inviting us.
Thank you so much for your presentation. Ed, you have a question?
Yeah, Dr. Brennan, during your presentation, I think you mentioned that the members of this partnership meet periodically to discuss how they're going to collaborate and to set priorities. What's an example of a priority?
I just want to correct you, I'm not a doctor. I'd love to be one.
Okay.
Well, we set priorities based on our community needs. For example, we've identified that pharmaceuticals are an important issue for our project. Our patients come out of the hospital, they may not have a prescription in hand, or they may have one and they don't know how to fill it. So that for us was a community issue that we needed to kind of wrap our arms around. And so we created a pilot program that looked at that pharmaceutical need and created co-op on a pilot project and worked through that issue. So that's an example where we tried to resolve a gap in our community with people walking with a prescription, kind of met, talked about it, brought all the correct partners that are involved in that together to the table, and found a resolution for our patients so they could go with medications and have those patients also moved into a Pecan home. So we case managed them once we identified they had a need and had a prescription, and we helped to move them into primary care so that they wouldn't go back to the hospital again and use medications in the hospital and kind of go through that cycle again.
Carl?
It's very impressive, the extraordinary amount of volunteer investment in this program. I mean, there's a redistribution of public money or redirection of public money, but it seems to rely so much on voluntary contribution of medical and related services. What's the glue that holds that together, and what sustains that?
Well, I think the glue that holds it together is really the collaboration itself. Margaret mentioned about the agendas at the door. We really try to get things out in the open so that there's trust in the room. We meet monthly, and everybody is usually there, and we try to work together. Also, in setting the kinds of outcomes that we measure, we have 4 categories of outcomes. We have uninsured, non-urgent ER visits. We have an extended hours pilot. We did evaluation on patient health outcomes in the clinics, and we did evaluation on what the partners think about the collaboration. So if you think about all those evaluations and all these different kinds of agencies at the table, it shows that there is something there for everybody and that it's the win-win.
Maria?
I was struck by the heavy emphasis on $5.3 million worth of service, volunteer. So in essence, you've got a network of for-profit, nonprofit, public, uninsured, an incentive to reduce emergency room visits, et cetera, and then providing health care. What percentage is really sort of through volunteer provision of services?
We have 4 volunteer agencies that make up the Pecan Partnership. And together they combined, they served about, maybe 10% of our total population is served by the volunteer network. Last year alone, they donated $5.3 million in service. So we augment what the volunteer network is, a component and a very important part of our network, but not all of the network. And I think the beauty about our relationship is we did an inventory of our community to see what services were available, and the faith-based partner was out there. And so they started together, we all collaborated together, and it grew, and it continues to grow. It started with about 200 volunteers, and we're up to 1,600 volunteer professionals because everyone wants to be involved and everyone wants to do their part. Again, it's a community effort. So it's great for us to see that we have funneling of funds that come in, but also this wonderful donation that comes along with it, with either our physicians or our community partners. So we have that combination of in-kind as well as some financial support.
David and then Bill.
Your application talked about medical homes for your patients. And I've discovered that that's the new phrase that means different things to different people. So by that, do you just mean a primary care physician for that person, or do you mean more?
We've defined medical home as a regular source of health care. In other words, a family doctor.
Thanks.
Following on that, I gather that some indication that a shortcoming of the program is that the specialists have not been participating at the same, there are not as many access to specialists in the medical field as in other areas. Is that a problem that you're addressing?
I'm not sure that maybe we address that properly, if that's the impression, because we have a lot of specialty physicians, Margaret.
Yes, we are partnered with the Medical Society, for an example, and so we have over 400 physicians in the community, many of which are specialists. We knew that when we grew primary care, we would have a need for specialty care. And so we continue to recruit. I think as long as you have doctors, we want to get them on the table with us. And we have a specialty care clinic that it's co-op. There's about 200 specialty physicians that float through there every day. We staff that with 30 different specialties. But we also have volunteer physicians in the community that take care of patients for acute needs. We're partnering with our new medical school in the hopes that the physicians there will also be part of the volunteer experience in their rotation through medical school. We already have a residency program with 3 years of internal medicine residency practicing and seeing our uninsured patients. So basically what we do is whatever we can get, we add to the party and to the table. And many volunteer physicians want to participate. They just want it to be made easy. They want to come in, see the patient, and go home. And that's what we try to do. There's always many more, but we have tapped into many.
Well, you guys are filled with enormous passion for what you're doing, and you can see it in your presentation and the love that you're giving to this program and to the people you serve. So congratulations. Thank you for coming.